Good morning, everyone. Welcome to our UCT-African virtual meetings. Today, we'll be discussing a few cases with our radiology team. Just as a reminder of some of the house rules, please remember to keep your microphones muted. If you have got any questions, you can either use the raise hand function or the chat function, and we'll make sure that your question is addressed. So without further ado, I will start with our first case presentation. So I'll be giving the history and the clinical findings, and the radiologist will take us through the imaging that we requested. So our first patient is Miss JD. She's 34 years of age. She presented with a year history of proptosis of the right eye with associated epiphora and blaring of vision with diplopia. She also had right nasal blockage with intermittent hyposmia and had associated right frontal headache. She didn't have any epistaxis, no history of any trauma. She didn't have any constitutional symptoms, no recent TB contact. She didn't have any allergies. She didn't have any significant past medical history, no previous operations or any nasal operations. She smokes. She used to smoke 4 to 5 cigarettes per day, and she was an occasional alcohol user. So I would go on to mainly focus the examination. So in examination of the eyes, she had the right exophthalmos or proptosis with a right eye dystopia. So the eye was basically displaced inferolaterally. Her visual acuity was intact, color vision was also intact, and her extraocular eye movement was also intact. A cranial nerve examination was essentially normal. Neck examination was normal, as well as the rest of the examination was normal. So we ordered a CT scan for this patient, and radiology will take us through the CT scan findings. Over to you, radiology team. You can go ahead and share your screen.
Good morning, everyone. I'm Dr. Iman from Department Radiology at Groote Hospital. Me and Dr. Ahmed will be presenting the cases. So first patient, Mrs. JD. We have a contrasted CT scan, just coming down from the vertex. We firstly see the area of concern, spansal homogeneous high density lesion in the right anterior ethmoid sinus, expanding the sinuses in that region. As we already can see on this brain window, that the soft tissue mass is projecting anterolaterally into the right orbit with loss of this bony outline as the mass is causing thinning and resorption of its surrounding bone. The mass is then displacing the orbit and the medial rectus muscle laterally with resultant proptosis of that right eye. The mass just caused further expansion of that sinuses, but furthermore, there was no other areas of pacification or high density lesions within the paranasal sinuses. The remainder of the brain was completely normal. I just want to demonstrate the bony remodeling and thinning on this bony window. As we can see here, marked thinning of the surrounding bony structures was marked expansion of the ethmoid sinuses, and then the loss of bone in the anterior lateral compartment. And just on the coronal imaging, we can appreciate again how this mass is expansile, but the cribriform plate remains intact, so there's no extension into the brain, also not crossing the midline. Our final differential was that of a mucocele for this patient due to its more benign and long-standing appearance. Thank you.
Okay, thank you very much. I will open up to any questions from the floor.
Just ask, is there anything else in the differential, or is it just mucocele from a radiology point of view?
So is there anything else in the differentials, or it's just a mucocele? Is there anything else we can include as part of the differential?
I think that the appearances on CT are typical for a mucocele. I didn't consider anything else in the differential diagnosis.
Dr. Charles, what was that?
I think this patient has. I had one more question. So, if this was an infected mucocele, like a mucopuracele, or if there was some fungal superimposed infection, what sort of features shall we look for, as opposed to this sort of like a simple mucocele?
So I think you may see that the contents of the mucocele are probably more high density in the CT scan, and if it's quite a good going aspergillus, I suppose you could see some more destruction.
So this is how we manage this patient. So the patient had surgery at right ancynectomy with mid-meatal antrostomy and the drainage of the mucocele. And then subsequently, when she was followed up, the symptoms had completely resolved, and she was discharged after about 8 months follow-up. So I'll go on to case number 2. Case number 2 is Mr. J.M. with 15 years of age. He presented with a progressive left nasal obstruction for 2 years, which was now involving the right side with recurrent severe left-sided epistaxis. He missed quite a significant number of school days and required multiple admissions with the anterior and posterior nasal picking. He also had hyposmia, associated left frontal headache, no focal neural signs or no history of any seizures. He didn't have any orbital symptoms, no facial paresthesia. He was a simple snorer with no apnea episodes, and he had associated fluctuating subjective hearing loss on the left side. As I have noted previously, he had multiple admissions for recurrent epistaxis and was missing significant number of school days. And on examination, basically the cranial nerves 2 to 12 were intact. He didn't have any proptosis. There was no premaxillary swelling on the left side. And on nasal examination, there was a pale gray polypoidal mass which was arising from the left milk meatus. In eye examination, visual acuity was intact. Yet normal extraocular eye movements, color vision was also intact. His rest of examination was normal in terms of ear, neck, and oral cavity. So I will allow the radiology to share their screen and take us through the imaging that was ordered for this patient.
Okay, for patient JM, we have this contrasted CT brain. As we come down, we can see there's a heterogeneous but appearing to enhancing mass in this left nasal cavity. It has marked a mass effect as it is causing displacement of the medial maxillary wall laterally, so we can see bowing of that wall and also bowing of the medially of the nasal septum to the right. anteriorly, we can sort of see the extent of the mass close to the nasal opening on the left-hand side, and then posteriorly, more evident remodeling and destruction of the bone posteriorly with this thinning of the septum posteriorly, and then also at the lateral aspect of the pterygoid process, marked remodeling and destruction of the bone there as it is projecting posteriorly into the nasopharynx, crossing the midline and also almost involving the right nasal passage. There is then more inferiorly enlargement of the pterygomaxillary fossa, and as it extends to the pterygopalatine fossa into and the maxillary fissure into the infratemporal space, with enlargement of this region. And then just as we go superiorly, it also extends into the sphenoid sinus on the left-hand side. And I think from the infratemporal fossa, it is extending superiorly with enlargement of the infraorbital fissure to also involve the space as it encroaches onto the cavernous sinus here posteriorly. But the optic nerve itself and the orbit itself looks clear from this mass, but it is definitely enhancing mass with a heterogeneous appearance. And I can just show more of this bony remodeling and expansion on this bone window. Excuse me. Here we can see the mass again with this more expansion of the inferior nasal cavity or middle nasal cavity, and then displacement of the maxillary walls and the maxillary sinus appearing smaller, and then enlargement of the pterygopalatine fossa, and then destruction of the pterygoplates posteriorly on the left-hand side. We have an MR that was then performed just run, this is the T2 sequence sequencing. So to zoom this up a bit for you. So we can see this T2 heterogeneous signal intensity mass in this area of concern in the left nasal passage, and its extent anteriorly and then into the pterygopalatine fossa, and then posteriorly also into the sphenoid sinuses, and involvement of this inferior orbital fissure superiorly, and just associated the pacification of that left mastoid ear shells as expected. On our enhancing imaging, I mean, this mass didn't demonstrate any signs of restricted diffusion. So just concentrating on our enhancement, we can see that this mass is avidly enhancing, picking up lots of contrast, homogeneous outline, but internally we can see this heterogeneity with low signal intensity and the signal flow voids, as represented by this linear or more serpiginous T1 low signal intense areas. And we can just appreciate the extent of this lesion further into the infratemporal fossa and superiorly into the sphenoid sinus and into the infraorbital fissure, as mentioned before, and its encroachment or close relation to the cavernous sinus and almost ICA on the left-hand side. So yeah, furthermore, I mean, there was nothing else in the brain and no dural venous sinus fibrosis or anything that that could be of concern. So our differential or final diagnosis is that of a juvenile nasal angiofibroma, and with the extent of involving the infraorbital fissure on the left-hand side.
Precious, can I just ask, for the purpose of those doing exams, can you go back to the CT and show us the pterygopalatine fossa on the normal side?
No, look, man, that's so bad. I ain't there.
And so I want to see the sphenopalatine for airmen the pterygopalatine fossa and the Vidian canal. Would you be able to show us that on the normal side?
Yes, I can definitely.
Thanks.
So yeah, this is on the right is the normal side. So this is where our pterygopalatine fossa is, going into the pterygomaxillary fissure to laterally. Posteriorly, if I have it, this is the foramen rotundum, I'm not mistaken, going this way. Yeah, but it's just behind the maxillary maxillary sinus on the we have this is where the pterygopalatine fossa is.
Thanks.
Did I show them all?
No, that's fine.
Yeah,
Thanks.
hi, sorry, it's Darlene here. I think it's easier to see that foramen rotundum and the Vidian on the coronal. From from a resection point of view, what's important for the surgeon to know always, I mean, it's relatively easy now with with the endoscopic Denker's approach to get good access to the pterygopalatine fossa and the infratemporal fossa. So those areas and even the fissure is not a problem. But what I like to know usually is the involvement in that sphenoid sinus, the Vidian canal. You see if that is kind of infiltrated or involved or enlarged, then there's going to be a big supply from the Vidian artery, which is obviously kind of internal carotid artery system, which they can't embolize for us. So despite embolization, you're going to get a lot of bleeding at the last bit of the dissection. And then also to know that these tumors are usually almost always pedicled on the posterior septum. So you have to do a kind of a posterior septectomy. But what makes it especially difficult is if that tumor is, and in this case it's really got a very wide base on the nasopharynx. So it was really pedicled on the posterior septum, on the rostrum of the sphenoid, and the nasopharynx, and endoscopically all open. That's very difficult because you've got the whole tumor out, and then you need to try and rip that last little bit off, and that's where you get extensive bleeding. So I'm not sure if you can, maybe on an MRI, probably you can be able to tell us whether it's normally pedicled on the nasopharynx or not, or is that difficult to say?
Sorry, Prof. Libbe, were you asking whether there's extension into the nasopharynx?
Yes, like in this case, there was extension. It was really stuck on the nasopharynx, so it's not like the tumor is just kind of abutting it. So when it's stuck on the nasopharynx, that last little bit, we normally deliver it through the mouth. But when it's stuck there like a piece of adenoid, you can't actually cut it. It's very difficult. So it's quite useful for us to know that beforehand, that one is going to struggle there, because then you actually need special instruments, either a coablator or an ultrasonic dissector to really make that bit easier.
So you can see this is the nasopharyngeal area over here. You can see it's completely obliterated. There's nothing there. Just click on sagittal for me. So if you look at the sagittal, there's this huge mass. This is nasopharyngeal area over here. It's completely obliterated, as you can see.
Yeah.
So it's a huge mass.
And it was fixed on that almost clivus, that rostrum floor of the sphenoid, the clivus. You can see that nicely in that image. So that would be nice if one actually can comment, or I suppose if one has an MRI, if one can comment on the infiltration of that area, because then you know that, for me, that's the most difficult bit to get out.
Sorry, this one. Okay. I just want to show you the MRI quickly. Just this, yeah. This one. Which one is this one? Even this one is it? Yeah. This another one. The axial. This one. Which one? Give me 1 second. There we go. So this is the Yeah, so I think you can see it's going right up against the clivus at the back here, this entire mass. It's a huge mass there. Yeah. And then this is the prevertebral muscles over there, so it's going right up against it.
Can I ask Dr. Ahmed, for these cases, you know, I often think it would be so worthwhile to have an MRI like the next day to see whether there's a little bit, you know, it's like that little bit in the inferior orbital fissure, whether we actually managed to get that out or not. What would you say is the cutoff time to be able to distinguish between residual tumor and just kind of inflammatory post-surgical changes?
Is this now after the surgery?
Yes, after surgery.
So after surgery, are you looking for any residual tumor soon after surgery, in other words?
Yes, yeah. So because often it's difficult to know whether you actually manage to get all of these little bits and pieces out, you know. Do you think it's worthwhile doing a scan like after 24 hours?
I think after 24 hours, I mean, this looks like major surgery to me. So I suspect, you know, there'll be quite a lot of inflammatory change still around, and it may just be difficult to, you know, ascertain how much residual tumor there is or not. I mean, if that was the case, you know, if would you take the patient back? In other words, if you know that there was tumor still maybe the next day or so.
I think we probably wouldn't take them back immediately because they've usually got quite a bit of a blood loss, but we'll probably take them back like at 6 weeks. So maybe one should do an MRI at 6 weeks.
Yeah, I think so, because I think by that time, you know, all the post-surgical inflammatory changes would have settled, and then you'd get a better idea of, you know, what is left behind. I think so. I think our experience with other you know, with other pathologies also is that if you ask for imaging so soon after a procedure, you often cannot establish what is inflammatory or post-surgical, or, you know, what's residual sometimes.
Okay. Thanks.
Okay, there's one question from the floor from Joshua. He's asking if you could kindly show us the clivus on the CT scan.
Sure, no problem.
Which one? Where's the sagittal? Let's just share this one. I'll show it to you now. MPR that one. I'm just going to MPR the CT scan for you, and then we'll show you the clivus. So it's probably best seen on the sagittal view. So that's the clivus area there. Can you see it? That's the clinoid process there at the top, and then this is the sphenoid sinus here, and anterior to that would be the ethmoid sinuses, and then that's the peg, and then there's the anterior arch of C1, and that's the hard palate over there. Okay.
Okay, thank you. Maybe from an exam point of view, I know this is sort of like a typical presentation of a JNA and typical imaging features, but what other differentials can we think of, like any other vascular tumors like lymphangiomas or hemangiomas in that area that you know?
Yeah. So I think because of the history that you gave, I think you know, the recurrent epistaxis, that's quite a typical history for a patient with a juvenile angiofibroma. I suppose you know, with the some bony destruction, that I suppose you need to consider a nasal mass, a nasal tumor like a squamous cell carcinoma. I suppose you need to consider something like lymphoma as well. So those probably would be the main things to consider in the differential diagnosis.
Thank you.
Okay.
I'll go on to the next case. Okay, before I go on to the next case, so this is how we manage this patient. He had pre-op embolization or neurosurgical colitis, and endoscopic sinus surgery for excision of the JNA. It modified Denker's ancynectomy, anterior posterior ethmoidectomy, posterior septectomy, bilateral sphenoidotomy, and the rostrum of the sphenoid was also removed. So these were some of the findings. The posterior wall of the maxillary sinus was eroded, and there was trauma in the pterygopalatine and infratemporal fossa. With the internal maxillary artery was identified and ligated, and there was also tumor over the left internal carotid artery, which was cauterized, and there was, of course, a risk of recurrence over that area. There was the high likelihood of residual tumor, and as well as a risk of recurrence on the orbital apex. So I'll go on to case number 3. Case number 3 is Mr. AI. He's 24 years of age. He presented with the right nasal obstruction for a year with associated anosmia, had a purulent right nasal discharge with associated epistaxis and a postnasal drip. He didn't have any comorbidities, no constitutional symptoms, no allergies, no orbital symptoms, and no significant past medical history. On examination on the nose, this pink with most likely vascular mass originating from the left mid-meatus and extending into the postnasal space. Eye examination was normal visual acuity, color vision, and extraocular eye movements. Cranial nerves were intact, and rest of the examination was also normal. So I will allow Cassius, I will allow you to share your screen again and take us through his CT scan. You are on mute, Cassius.
Thank you.
Okay, maybe you can just okay, yeah.
So, yeah, this is a CT brain on a soft tissue window that was performed for Mr. AI's sinuses. As we come down on this axial slices, we can see the frontal sinuses are well aerated. The orbits are symmetrical and clear, no pathology. Ethmoid sinuses on the left and right is also clear. And then as we come down, we can see in this left maxillary sinus in the antrum of the left maxillary sinus is more discrete opacification with extension. You can appreciate extension into the nasal cavity and projecting posteriorly towards the nasopharynx. And we can also see that this has a more rounded appearance. And the density appears to be all homogeneous and similar. We measured the Hounsfield units of this. It came to about 20, which is in keeping with more like a fluid. Slightly more protein containing fluid per se. But otherwise, we didn't, this area of opacification doesn't cause any destruction of the bone or thinning, maybe slight thinning of this medial aspect of the maxillary wall. But otherwise, I mean, there's no real expansion or displacement or resorption that we can appreciate. And then just lower down, more gravity-dependent opacification of the maxillary sinus. I can just show in the coronal images. Coming from the front, so we've got an inferior nasal turbinate here, and then we get the opacification in the maxilla with appreciation of that opacification or low density crossing into the nasal passage and then extending posteriorly towards the nasopharynx posteriorly. Just to demonstrate on the bony images, this area of concern, and as we can see here, a smooth outline anteriorly, and then projecting with more of a globular, rounded appearance posteriorly towards the nasopharynx, and then further just opacification of that floor of the maxillary sinus. So this appearance and the area where which is of concern here, which is the maxillary antrum, and that the rounded appearance of this posteriorly projecting lesion is in favor of that of the anteroconal polyp. Yeah, there was no destruction or expansion or bony thinning that would that gave us a thought of another type of differential. We could perhaps consider just a rounded, more polyp appearing appearance of this to be some kind of polyp, but the area of origination and the projection posteriorly favors that of anteroconal polyp. Thank you.
Okay, thank you. I'll open up for any questions or comments from the floor.
Can we maybe look at the coronal and just see? I've often found with anteroconal polyps that they actually come through and an accessory fontanelle or the accessory ostium posteriorly. So can we actually see whether this comes through the normal ostium or accessory? I'm not sure. Has this patient hasn't had previous surgery or had?
No.
It's just an interesting finding that you often find that if you remove these, that you actually need to find the normal ostium a little bit more anteriorly, so you have to communicate them. So things difficult to see. If you look on the opposite side, you can see there's an accessory fontanelle.
Yeah. So I mean, there's the osteometal complex on that side.
Yeah.
And then on the side, here's your osteometal complex here. So that's your uncinate process over there, and that looks a bit opacified. And then looks like this thing is going through here, isn't it? And then coming into the nasal cavity.
Yeah, so it actually does look, and on the opposite side, and on the same level, you also see an accessory fontanelle.
Yeah, yeah.
And it looks like it could be an early anteroconal polyp on the opposite side as well, going to do exactly the same.
Yeah. So we of course what comes into the differential diagnosis with this lesion is an inverting papilloma, but I think the absence of the there's no bone changes that we see over here. There's no bone remodeling or destruction, so that made us tip towards anteroconal polyp.
Okay, good. Just on the opposite side, if you look at that tooth, is there a cystic lesion related to the root of the tooth there on the right hand side? I think if you go back a little bit there, I just saw.
Yeah.
Just now, where is it? You should see there's like a little.
There.
No, there's a little space. Just run through it. I think more on the posterior aspect.
Posteriorly, yeah. So we're going quite far back now.
Yeah, okay, no worry.
I don't see anything that's really...
Okay.
Okay, thanks.
Okay, thanks, Cassius. Okay, so apparently this patient was lost to follow up due to the COVID pandemic. So I will go on to our fourth case. So our fourth case is Mr. MT, 71 years of age. He presented with the right nasal mass for 1 year with associated right nasal blockage with occasional epistaxis. He also had right-sided epiphora with mucoid rhinorrhea, no headaches, no orbital symptoms, no ear symptoms. He was an ex-smoker. It stopped about a year prior to presentation. And basically on examination of the nose, we had this nasal mass, which was completely obliterating the right nasal cavity. There was no contact bleeding or any blinding. Eye examination was essentially normal, and cranial nerve examination was also normal. The rest of the systems were unremarkable. So, Acacius, I will once again allow you to share your screen and take us through the imaging for this patient.
Okay, so Mr. TM had a cone beam CT with us, just coming down on these axial slices of the cone beam images of the sinuses. We can appreciate the pacification of the right frontal sinus here, but well-aerated left frontal sinus, and we can see that the bone here is a bit more hyperostized, a bit more sclerotic. Furthermore, the remainder of the superior ethmoidal sinuses are also opacified with osteosis of this bone, as we can appreciate, comparing it to the left-hand side. And then also opacification of that right sphenoid sinus with also osteosis. But then more discrete finding is this complete opacification of the right nasal sinus with what appears to be an expansile mass displacing this medial wall of the right maxillary sinus with thinning wall, and then also displacing the right the nasal septum to the left. This mass is completely opacifying the posterior aspect of the nasal passage with extension into the nasopharynx and opacification, attenuation of that nasopharynx posteriorly. And then just complete opacification furthermore of this maxillary sinus. We can also appreciate loss of the normal nasal turbinates, and we just see this area of calcification that's remaining in the nasal passage. Not clear. Yeah, that is probably more like ethmoidal trabeculae and bones, but difficult to say which exactly is the origin. And just on this coronal imaging, you can appreciate this expansile soft tissue mass in the nasal passage with displacement of the middle wall of the maxillary sinus and nasal septum, and then just coarsened bones remaining within this area of opacification, and then as it extends anteriorly towards the opening of the nose on the right. So just comparing these images to the previous one, where we have in this case more bony remodeling and also a resorption and just some bony flecks remaining. We favored this to be that of an inverting papilloma, being more of a still having a benign appearance with a chronic appearance, but a more bony distraction compared to the antroconal polyp in its extent. And then, sorry, just to mention the hyperostosis and opacification of the other paranasal sinuses was thought to be that of due to chronic sinusitis. Thank you.
Thank you, Cassius. I will open it up for any comments from the floor. Questions?
Sorry, so just from the imaging point of view, you could, if you compare this case with the previous one we called an antrocanal polyp, and then this one we are calling a inverted papilloma. So you can just appreciate that if you just look at the bony remodeling and destruction compared to the previous case, And then also, you know, the large mass in the nasal cavity causing the pansinusitis with extension posteriorly. And then with MRI, if you were to do an MRI, you'll get intense cerebral, sort of a cerebriform type of enhancement. And that's typically called sort of brain in the nose kind of appearance.
I'm going to ask now, the features of hyperostosis, I mean, is that quite specific?
If you, sorry, the hyperostosis features?
Yeah.
You're saying, is it typical for inverting papilloma?
Are they quite specific?
Yeah, I think generally what is described is that there's bony remodeling. I'm not sure about the hyperostosis, but I think that may be because of the fact that there's been chronic sinus obstruction as a result of this mass, resulting in that hyperostosis of the bones around the sinuses.
Maybe Darlene can comment on that.
Is Darlene still there? Okay, thank you, Cassius. Maybe from an academic point of view, if so, how can we differentiate a purely inverting papilloma versus an inverting papilloma with a malignant transformation or some features of malignant transformation? Which features shall we look for versus, you know, a pure malignancy like in a sinonasal cancer? So how can we differentiate that from a CT?
So I think what you would probably see if it was an inverting papilloma that has malignant transformation, you're obviously going to see signs on CT of a destructive type of lesion with much more bony destruction. I think that would probably be the main feature on CT. This is a cone beam CT that we looked at, so it doesn't really show the soft tissues very well. And I suppose what you'd probably have to do is do a contrasted CT. You'll probably see enhancement of the mass, and you'll see the associated bony destruction. If it was a sinonasal malignancy or if it was an inverting papilloma with malignant transformation.
Okay, thank you. Okay, so this patient subsequently had a biopsy which confirmed an inverting papilloma and had a right endoscopic medial maxillectomy and endoscopic Denker's and frontal sphenoethmoidectomy with right sphenopalatine artery ligation and problem of the lacrimal system. And finally, histopathology results confirmed an inverting papilloma with no evidence of malignancy. So I will go on to case number 5. Case number 5 is Mr. SS, 47 years of age, male. He was referred from our neurosurgery and ophthalmology colleagues. He had presented with a 6 months history of reduced visual acuity of the left eye. It was non-progressive. He was being followed up by the ophthalmologist. But it was noted that it was actually of sudden onset 6 months prior to the presentation. There was no associated double vision, no associated headaches. There was no history of any trauma, no TB contact, no constitutional symptoms. It didn't have any nasal symptoms, no nasal discharge or nasal obstruction or post-nasal drip. And on examination on his central nervous system, didn't have any meningism. 30 to 12 cranial nerves were intact, and the eyes had normal extraocular eye movements with reduced visual acuity on the left side. Color vision was intact. There were no signs of cavernous sinus thrombosis, And due to COVID, it had an anterior anoscopy, which was normal. It didn't have any fiber optic nasal. So when they refer to us, this patient already had imaging CT and MRI. So Gracious, I will allow you to share your screen and take us through the imaging findings.
Okay, so we have a contrasted CT brain from Mr. S. The pertinent finding was this homogeneously appearing expansile component in his sphenoid sinus, projecting with bony thinning posteriorly into the posterior fossa almost, but no breach there, just bony thinning and expansion, and further expansion and remodeling of this sphenoid sinus posteriorly, and then also laterally bulging out the walls laterally, and further extension more superiorly and anteriorly. And on this left lateral component, we can see there's actually loss of bone on this soft tissue window, with this homogeneous low density extending into the region of where the optic nerve would be, but we can't really appreciate this very well. But this mass wasn't really enhancing and looked more homogeneous. This areas of low density is just technical due to beam hardening. Yeah, I just want to show you the bony remodeling and thinning. So from the top, we can see this expansile mass in the sphenoid sinus with its posterior extent. And then also, as mentioned in the left lateral aspect, breach of this wall projecting laterally and into the region of where the optic nerve would be, but in general, just a benign appearing, non-aggressive, just remodeling and expansion of sphenoid sinus. We unfortunately, sorry, only have a static image of the sagittal, and this is just to demonstrate the extent of the expansion as it goes posteriorly, but we can still appreciate the bone posteriorly as it encroaches into the posterior fossa, but the pituitary fossa was still normal and intact, and then the remainder of the brain didn't show any enhancing features. The MRI then performed 3 months later. This is the T2 flare image, which is going to demonstrate fluid signal intensity better. We can see this avidly, homogeneously at T2 flare hyperintense or high intensity within this area of concern of the sphenoid sinus, involving the entire sphenoid sinus, and as well as to the extent as it bowed into the posterior fossa. And then we can't yet appreciate this lateral aspect, which is also area of concern. And then just further the mucosal opacification and mucosal thickening and intensity. There wasn't any restricted diffusion or and just to demonstrate the appearance on T1, we can see this high signal intensity or mixed signal intensity in this area of concern in the sphenoid sinus, with areas of high signal intensity. Zoom in. Involving the entire area. Then lower intensity signal higher up, and just want to show you the area of enhancement, which will demonstrate our concern. So here we can see this expansion and the lateral aspect in the left lateral wall that was eroded or thinned out completely. We can appreciate extent of the lesion laterally encasing the optic nerve. Closely related as it courses to the optic chiasm here posteriorly. So we can see the lesion completely encasing this left optic nerve posteriorly just before its attachment to the optic chiasm here. And then just furthermore, the enhancing of the mucosal thickening and enhancing of the remainder of the sinuses, which we can appreciate here, some iso-intense signal intensity from that left maxillary wall, likely due to opacification with proteinaceous fluid. But we then actually just have in general, this mass. I just want to see if I can show it in another plane. On our coronal, you can appreciate this, the mass in the posterior, in the sphenoid sinus, do demonstrate differential signal intensity, but confined to that region. And then there's just the remainder of the sinus thickening and involvement of the sinuses otherwise, secondarily. But this lesion in the sphenoid sinus then at the features being non-aggressive and expansile of that of a mucosule, which extends laterally to encase the left optic nerve, which is likely causing its visual disturbances. And the heterogeneous or differential signal intensity within the mucosule could be due to evolution, either dehydration within the mucosule, or I think even hemorrhage has been described. And then just sinus disease in the rest of the sinuses. Thank you.
Thank you, Kate. I will open up for any questions or comments from the floor. So maybe Cassius, you can take us through some of the features. How can we differentiate, for example, if this was a chronic fungal sinusitis, chronic invasive fungal sinusitis, or how do we differentiate that from an acute invasive fungal sinusitis on the CT or MRI?
So I think with a fungal sinusitis, generally the main component would be that the contents would be high density or calcification within the sinuses, and then if it's an aggressive kind of sinusitis, you will get bony destruction and extension into depending on where it is, into various parts of the brain. So if it's the posterior frontal sinus wall, it will go into the anterior canal fossa. And if it involves the sphenoid sinus, it goes into So you look for things like intercranial extension. You will look for bony destruction and erosion, and you will look for calcification within the sinuses to show that's an aggressive fungal sinusitis.
Okay. And can you differentiate an aggressive fungal sinusitis from a lymphoma, from the CT, or it's
I suppose with the lymphoma, you'll have a more mass-like homogeneous, probably enhancement of the mass with associated bony destruction. You probably wouldn't have the different fluid density components that you are seeing on this particular scan. With the lymphoma, you can get necrosis, I suppose you get a necrotic component. So I suppose you could, because as I said, sinusitis would probably have thickened secretions and calcified secretions, whereas a lymphoma would probably be more solid than a fluid sort of density.
Thank you very much. You wanna allow me to share my screen? Okay, thank you. So this is how we manage this patient. He had surgery, he had bilateral frontal sphenoid midectomy, there's a septoplasty and a drainage of the sphenoid mucosal. And then on culture, we grew aspergillus fumigatus, which more likely pointed to a chronic invasive fungal sinusitis as well. This was our last case for discussion. Thank you very much. Special thanks to our radiology team for joining us for this UCT-African Zoom meetings. And thank you very much everyone else for taking your precious time and joining this wonderful discussion. So our next meeting will be next week on Wednesday, and you will receive the Zoom link on our UCT WhatsApp platform or on your email addresses. Thank you very much for attending.